That means that when we then do a pressure pain threshold test or a temperature pain threshold test, that the sensitivity is reduced. I've just been told that I'm now moderator. So the pressure pain threshold is reduced, and so that we get this benefit of stimulating the internal drug cabinet in our brain for flushing down these chemicals that act at the dorsal horn of every level of our spine, which is bringing in nociception potentially from different body parts. I'm going to upload this paper and take you guys through it now, because it's really helpful for you to see and appreciate what the difference is for people in persistent pain when you give them exercise compared to people who don't have persistent pain, because it is different, and it's so important for how we communicate exercise with people in back and neck rehab. Because what can happen is when we do the same exercise, so someone's got neck pain and we give them shoulder exercise or exercise in the area of the body part, they don't get the drug cabinet that comes in and reduces sensitivity. Often the complete opposite happens, where it will enhance sensitivity and it will cause them a painful experience, which often leads people to, if it's not normalized and explained, it leads people to perceive that my neck is now injured again, I'm causing more damage by it causing a flare-up, as opposed to appreciating that this is a centrally mediated process and is actually dysfunctional for people with persistent pain. This paper here is a literature review last year on exercise-induced hypoalgesia. So exercise given to reduce pain or to reduce the input of nociception from the body. Okay, now you can have a look at this paper to be able to see a nice in-depth review, and I fully encourage that. If you can't get it, then contact me. But in this table here is a list on the far left here of different presentations. So chronic low back pain was in this study. That's the author. This is the type of exercise that they did to try and stimulate the internal drug cabinet in the brain, and the dose was 20 to 130 watts. So they were using a cycloergometer going up incrementally for 17 to 29 minutes. What they used, I'll just, let me just finish my flow, Martin, and I'll grab you, okay? What they used was pressure pain threshold. So they were able to say, so this is light touch, this is medium touch, and this is firm touch, to be able to press harder. And there's different measures of pain sensitivity, including VAS, including temperature, to be able to see the difference of exercise. Okay, and they had people who had no history of persistent pain and people who had pain, and they had a local effect and a global effect. So the local effect would be, we do this pressure threshold test on the painful body part, do the exercise bout, which may be, in this case, it was a cycloergometer. In this one, it was resistance, abduction of the shoulders, and it'll be some variation, anything from walking to swimming, and then retest it. And what you'll see on this on the left here is people who haven't had pain before. And this downward arrow illustrates that they had a reduced sensitivity post-exercise. And for every single exercise bout that you see in this table, every one of these is a different study. People without pain had exercise-induced hypoalgesia, which means that they stimulated the internal drug cabinet in the brain. Let me just take this on a page for you. You'll see that this continues, and all of these exercise protocols cause exercise-induced hypoalgesia for people who don't have pain. what you will see if we come over to the next column, which is the painful group. So in this one, it's chronic low back pain. In this one, it's chronic neck pain. In this one, it's widespread pain. There's shoulder pain. They do the exercise, and if you look at these arrows here, they experience increased sensitivity, which means that it made their pain worse. And that's so important to be able to communicate and understand this, because a lot of people's experience will be, I tried rehab, it didn't work, because it wasn't explained the fact that this isn't causing your neck to suddenly, we're not causing more tissue-based damage here. But when we can appreciate these centrally acting mechanisms, there seems to be a dysfunction in that system for people with persistent pain. Martin.
Sorry to mess up your flow.
I didn't want to get lost. That's
That's fine. I just have a technical question about the paper. You said it's exercise induced hypoalgesia because of the stimulation of the internal drop cabinet, right?
Yeah.
So how did they distinguish between the descending pain pathway or pain inhibiting pathway and pain gating? Just out of interest.
Yeah, well, that's what your question is there, is ultimately talking about, it is pain gating, because these descending inhibition is the chemicals acting at the dorsal horn that are preventing the nociception from getting across the synapse to be then processed centrally. So how they measure that is, each one of these is a slightly different way of doing it. You can either do it with a von Frey fiber, where you get light touch sensitivity, or you can do it with temperature with an ice cube. I've got some videos of, and there's a paper by Beal et al. 2020 that demonstrates these tests. But you can then see the threshold that someone's pain experience is by these clinical tests, and it's reduced. So you ask, for example, Martin, on expensive equipment, you ask someone, you have a temperature thermometer. Are you following me, Martin?
Yeah.
Yeah, you have a temperature thermometer, so that you have a gauge that you put on someone's hand, and every second it starts at 30 degrees, and every second it goes down 1 degree. And you ask someone to say when that starts getting processed as painful. And people who have not experienced pain before, that would be a test, for example, you would do before and after a bout of exercise for the threshold that it would be processed as painful. And that's hypo and hyperalgesia. This is sensitivity. This doesn't describe the psychological component of affect. This isn't talking about disability. This is purely talking about sensitivity.
Okay, yeah, sorry, probably a misunderstanding, but I thought descending pain inhibitory is different than pain gating, because pain gating is stimulating the dorsal column, and that synapse is already in the spinal cord through the nociceptive fibers and inhibits them, and it doesn't go up to the. I think I'm misunderstanding something then. I don't know.
Well,
never mind. I'll look at somewhere. Thank you.
Let me play now, because I'm moderator. I'm going to play a video for you to see David Butler communicating this to a patient. Okay. Daniel, in answer to your question there, that's the interesting thing with the local response versus the global response, is that you could do this in the area where it's painful and an area that's distal that's not painful. And what has been shown in some of those papers is that you can give someone who's got a painful body part a bout of exercise, and we can still achieve exercise-induced hypoalgesia by exercising a different body part to the painful body part. Because when they exercise the painful body part, that can often make that, as you saw on the table there, makes their sensitivity increase. But we can, by giving them general exercise somewhere else, so in the neck, by giving someone lower body exercise, by giving them lower body exercise, we can still produce exercise-induced global hypoalgesia, and that is a really powerful, important point. If that helps, Martin, then great. Maybe I didn't explain myself before. But I'm going to play a video now that I send my patients before they come to session to prime them for these concepts. Okay. Share application screen.
About a remarkable thing that we all have deep in
Can you just confirm to me that you guys can hear that?
our brains? A drug cabinet full of the most remarkable pain-killing chemicals. This little cabinet is deep in our brains. This is my picture of the brain here. Put a little bit of hair on here just to orientate yourselves. Deep in our brains, we have areas that work together to produce remarkable pain-killing drugs. We'll draw it as a box for you. And we'll put a big cross on it. Now, if I was to ask you to name the painkillers that you can buy from the pharmacy, you'd probably name Nurofen, Panadol, Panadine. You would also be aware that morphine is a powerful painkiller. But can you name the ones that your own brain makes? For example, you can make opioids like endorphins and enkephalins. You can make serotonin. Your brain can even make morphine, and it's a morphine that's much more powerful than mankind can make. These are made in this remarkable drug cabinet. How does it work? Well, these chemicals are made and they trickle down the spinal cord. They also trickle up into the brain. Let's look at the spinal cord first. If these painkillers are trickling down into the spinal cord, then impulses coming in from the body telling your brain about warmth, cold, stretch, danger can be stopped at the spinal cord. It can stop any impulses coming up. But that's a great system. That's a great system. So how do we open and how do we close this drug cabinet? Well, the cabinet is under control from various areas up in the brain. And these areas in the brain talk to each other. They weigh up the situation of the world. We say they weigh the world. And they decide if it's worth opening up the drug cabinet. If it's open and the painkillers pour out, there'll be no pain. If it's closed, then impulses can come in and there will be pain. And of course, these areas of brain take their messages from the eyes, from the nose, and from the ears. The key question the brain has to answer to work out whether it's opening up the drug cabinet is simply, is it worth making pain? Is it worth having pain? Is it worth pain? So let me give you some examples. If you run and stub your toe while crossing the road and you have to get out of the way of the car, it often doesn't hurt. It might hurt when you get to the other side, but the brain's made a decision. It's not worth having pain now. Pain can wait. What it will do will be simply the flow, and there'll be no pain. Or you may have heard of people finishing a sports event with a severe injury. That person's decided it's important for me to finish this game, and therefore it's not worth having pain right now. In that example, open up the cabinet, flooded, and impulses get no further than the spinal cord. But it can go the other way too. If you put a pin in a violinist's finger, it hurts more than if you put a pin in a non-violinist's finger. Obviously, there's much more of a threat or a challenge if you put it in a violinist's finger, and the brain will think, hey, it's worth having pain. This needs protection. Let's close the box and have more pain. If you're scared about your back, if you're worried about that, the x-ray doesn't look too good, somebody said you're in a bit of trouble, there's a lot of degeneration there. If you don't understand the meaning of pain, then the brain quite rightly would make a decision, it's worth having pain here. Protection is needed, and of course pain is one of the greatest protective things to make you change behaviour. I should say, let's be grateful for the man-made drugs too, because at the right time and context they can help, particularly for acute pain or when there's inflammation happening. But the key thing is, for any man-made medication to work, it needs to kick in your own internal pain control system. If I was to sum this up, I'll do it with the key. What is the key to opening up the drug cabinet in the brain? To opening it up and flooding so we don't have pain all the time? Well, it's understanding. It's having support. It's having knowledge. It's having achievable goals. In particular, it's knowledge. I say that knowledge is the greatest pain liberator of all, particularly knowledge of how your body works.
Cool. I hope that is helpful for a visual for you guys to see where these mechanisms are taking place and how important it makes, you guys are going to be probably working a bit through telehealth, and being able to get education and adapting physical activity and exercise is two of your most powerful tools, not only when you're in person, but especially when you're working through telehealth, because we can still deliver those mechanisms. And one of the biggest things that gives me confidence of being able to help almost anybody who comes to see me is to be able to adapt the physical activity to the person. Because even if they've got pain, I mean, the worst presentation that you can think of in the world, from anything from schizophrenia to neurological diseases to cancer, exercise is as good a thing and it is beneficial for almost every single one of them. And being able to couple that with education is how we can stimulate and give someone the best chance of experiencing exercise-induced hypoalgesia. And if somebody would like to jump on and have a conversation with me, I'll go through how I would apply and get these concepts across to impact exercise prescription, which will be beneficial, hopefully, for you guys to see how you might use some of the tools that I've put into clinic for you there with David Byfield and Paul. Does anybody want to go on and have a conversation with me, just to be able to, so that I don't have to completely role play and imagine that there's a person on the other end?
Yeah, I can do that.
Is that Daniel?
Yeah.
We'll jump on Daniel, and just Daniel is the person who's going to get the benefits of this, guys. So each time I offer to be able to do this, if you can go through this, you're going to have take the confidence and the experience to be able to then go and apply it. But jump on, Dan.
Jump on the floor.
Just turn your camera on so I can actually have a conversation with you. Because we're gonna go through, Daniel, how I might try and utilize these concepts to try and impact the exercise, impact your program, because you're coming to see me because you've got shoulder pain or neck pain or back pain, whatever it may be. Do you want to pick one that you've come to me with?
I have a dodgy knee, so let's go with knee.
You got a knee pain, okay? So before this session, I sent you a video of a chap called David Butler, who's one of the leading researchers in the world around understanding the neurobiology of pain, and I find it helpful to be able to send that before the session. Did you see that video?
I did.
What did you make of it?
Yeah, it's quite interesting. About in internal drugs, sort of internal sort of healing and that sort of thing. Yeah, I'd be interested to learn more about that actually.
Oh, well, that's always a helpful thing for a starting point, because what we want to do now is try and put some meat on how we can apply using this idea of trying to stimulate, because we've all got that. I've got an internal drug cabinet in my brain. Every person has. And we want to make it make sense for you in connection to your knee. Okay? David said in that video there that one of the most powerful analgesics or painkillers we have is understanding. And that is important because up to this point, we've spent a bit of time going through separating tissue damage and pain, and how pain is an output of the brain, not an input, and how it can be set. It's multifaceted, so it can be triggered by lots of different things. And now that hopefully we're on board the idea that pain is an output and not an input, because when we appreciate that pain is an output, it helps us to be able to see that, that our nervous system is an alarm system. That is electricity, and it's designed to protect us. That's what it's all about. It's trying to protect us. And in some cases, it can become overprotective. Okay, and in that video that I sent you, that system that David was talking about, there seems to be some issues with that system in people like yourself who've got pain that won't settle down.
Yeah. Okay.
And that central changes. So we've done a physical exam on your knee. It's passed these tests. Now we're trying to make sense of why it hurts and how can we dial that nervous system down. That makes sense.
Yeah. Yeah.
That's really the goal of what our programs here are me working with you, is to try and help calm your nervous system down for your knee, and that'll help you get back to doing all the things that you said is important. What was it? Just remind me again what it was that you need to be able to do with that knee. Football, cycling. Okay, so we need to be able to get you back cycling. David Butler just drew on the board with a cartoon version of the brain. Here, I just want to show you some scans of what that might look like on an actual MRI scan. So if I was to put you in an MRI scan, this would be a cross-section of your head, okay? As a cross-section about this point of your ears. And you'll notice that you don't need to see it in detail, but it's nice and quiet. But if I was to get somebody, and what happens here is somebody moved their painful body part. So if I was to get you to move your knee into flexion and extension whilst doing the MRI scanner, what we would see on the MRI scanner is metabolic activity in all these different brain regions as part that illustrates your pain experience. And that tells us a few things. It shows there's not one pain center in the brain. It's in all of the different parts of your brain. So it includes your experience, your movement, your visual part. All of these make this complex circuitry of your pain experience. But in just going through 4 or 5 sessions of pain education, of some of the things that we've talked about, like tissue damage and pain not being one and the same, like pain being an alarm, like different things like temperature and the immune system and different things in our receptors can set it off. What happened then was purely through education, re-scanning this person, they get them to do the painful movement in their knee, and you will see much less metabolic activity in the brain on that MRI scanner, which illustrates that purely through education and reducing the threat of, I'm not causing more damage in my knee, illustrates that we are desensitizing our nervous system in terms of the pain experience. And that's putting a little bit of weight on what David was saying there around how education understanding is a painkiller.
Yeah, so you're basically saying the more I understand, and then manage the pain moving forward and hopefully eliminate it.
Exactly, and that's really to hopefully give you some meat on how, in this stuff that we're talking about and going through, if we were to MRI your brain, well, we're not going to do that because it's expensive and unnecessary, but look at the research to be able to show that we would see your nervous system calming down in terms of the response to protection of your knee.
The pain sort of increase or decrease due to like me worrying about my knee. So if I was like anxious about it, would that then increase the pain?
Well, in terms of plausibility around, there's some of the things that we're going to talk about here now, because that's exactly one mechanism that would, well, if you're anxious, you tell me, would that increase or decrease the threat?
Increase.
And how we can appreciate the nervous system is this balancing act of threat and safety. That's one of our jobs of the rehab program, is to find where you're at and be able to alleviate that anxiety to get you, we know that's going to improve your pain experience. And the ultimate goal is that through doing that is that we're trying to bring that sensitivity down.
Okay.
And there's lots of different things that can do. Standing is one. Another way that we can tap into your internal drug cabinet in your brain is aerobic exercise, or exercise full stop. And that doesn't have to be running marathons. It doesn't have to be doing crazy intense activity. In fact, research has shown that if I was to give you a very prescriptive 75% heart rate, this is from the Rice paper that I've just given you guys, if I was to give you a very prescriptive amount of exercise versus saying to you, Daniel, right, what exercise do you enjoy doing?
Riding a bike.
You enjoy riding a bike? Or what?
Walking.
We both jot those things down. I'd like you to jot those things down, because riding a bike and walking, they're going to become part of your program. And I want you to do as much as you feel comfortable to do. And actually, the research shows from an exercise adherence perspective, if you feel confident and safe that you're not causing more damage, by you doing a self-paced program, you are more likely to actually do it than me giving you something that is going to say you have to do this amount of time and
reps, etc., etc.
So you've just jotted down a couple of things that are going to be part of your program, and we need to make sure we can get a plan so that you can feel confident doing that.
Okay.
So what we've just got there, walking and cycling. One of the biggest things, the biggest barriers for working with pain, and it's challenging for me as a healthcare professional as well, is knowing and doing those things when it hurts. Am I causing more damage? Should I push through? Should I back off? That's such a difficult one for you with your knee pain, but also for any person who's going to help you. So we've got to put a process together to try and navigate that. And as long as, until we can get that we are not implicitly embodying that hurt doesn't equal harm, we're sore but safe, going back to that assessment that I did with you on checking your knee out, we are not going to be able to be really, really engaging with the discomfort when it happens, when we're walking and when we're cycling. Okay, so that's where the education and this stuff that we're talking about, I don't even like using the word education because it insinuates that we're uneducated. It's just talking about these concepts that I think are important for understanding how we get to navigate this. Some people, from my sporting background, have a very old school approach to going through your activities now, which would be, I've got training and I've got my goals and I've got to crack on because it's in my program, I've got to get it done, and I will just crash on even though it's hurting, and then ultimately it will get really painful, then I'll have to stop and I'll wait till the pain goes, and then I'm going to go real hard again. And that would look a bit like this, with a boom and bust pattern to the boom and bust approach to certain activities. And if I was to bring that back to myself, Daniel, I'm a nightmare for that with my training. I am a nightmare I know that I should probably back off or deload, but I've just got to get it done. So, I'm not immune to this. Is there any activities that you would be able to identify a boom and bust approach within your day-to-day experience up to now with your knee?
It would be the cycling. I do like climbing hills. I know with a bad knee that's not something that is the most ideal.
You find that you got to.
Because as you're going up, you start feeling the pain, and you think maybe just increasing my knee strength on the flat and that sort of thing. Yeah.
So that's really important. I want you to jot that down, because you may think of some other ones after this session as well, but we're going to want to be able to pace and break down some of the activities that we may be a boom and bust approach to, and it's going to help for me to be able to help you, keep you accountable to that.
Mm-hmm.
Just things like going uphill. Maybe is there any way we can change that for a while and take a different route so that we can not have hills, or we do. I want you to come up with some ideas around that, and then I'll support with some.
Yeah, well, I was thinking, instead of gradual, really long gradual climbs, more like interval training, smaller hills.
Really good idea. Yeah, I like that. Right, so that's boom and bust. Now, there's another approach that people will have when they try and go about their activity, and it hurts. And that will be, I'm worried about causing that knee problem that came on when I was doing this sprinting last time, or I was going uphill, and we back off from doing that task, and we are fearful of doing it. You mentioned this before, and we do the activity, and then we back off out of worrying about causing problems, and then we go and do it again, then we back off, and we over time are ultimately able to do less of it because we're fearful of it and doing it less.
Okay.
That's something called fear avoidance, and again, in the long run, that's not going to get us back to the work or to the sports that you want to be able to do.
Sort of the level I was at before the injury.
Yeah, so I mean, is there any parts of your experience so far where you would say you have more of a fear avoidance approach rather than a boom and bust?
Not right now. I mean, yeah, not off the top of my head, no.
That's fine, and that's everyone's different. And if there is any things that we're fearful of, and we're not doing it. And for example, I've dislocated my shoulder, and I am definitely apprehensive and fearful of this position overhead. Okay, but if in the example that was important for my sport that I want to get back to, and I'm not doing it, well, I would need to find a way to grade in towards doing that and to be able to work on that. So again, if there's anything that you've identified, I've stopped doing that, then let me know, and we can build that in as part of the plan, and we would start grading so we're going to pace the things that we're boom and bust with your knee, but we're going to start grading and going with things that we're fearful of.
Well, I think one thing that was actually is when I do go hiking is walking over loose stones and that sort of thing. So I find the extra sort of moving, my feet slipping and whatever, does aggravate the knee a little bit.
That's a really great example, and that's often I'll find that after we've had a conversation, you'll think, oh fuck yeah, I remember it now. So jot it down, and you can either send it to me via email. That's a really good example. If we want to get you back hiking the hills again, and we're not doing that in any way, then we need to find a way between us to start working towards that. Mm-hmm. A really challenging thing to be able to go about that is because if we don't want to be boom and bust, crashing through, just saying, right, just go hiking, and we don't want to say be fear avoidant because we don't want to cause it, we want to try and apply this sort of Goldilocks idea of touch it, nudge it, tease it, where we're going to agree to go at an activity, and it could be walking, it could be butt cycling, and we're going to have a level of discomfort that we're going to say that we can engage with. Hurt doesn't equal harm, sore but safe, but also respecting the fact that we can't just disregard pain. That would be boom and bust, and that sensitizes us. So that's easier. That's easy to see as a concept. Yeah. It's a little bit more challenging to put into practice, and that's why we're going to be able to be going through a little bit of a trial and error between us, because I don't know how much you can do until we do it.
Yeah, so you can tolerate before having to stop and then kind of go back at it again.
And the idea of if we can do that, and if we can touch it, nudge it, tease it, is that over time, sore but safe, that's what these say here, it doesn't equal harm. If there's any other helpful metaphors that you have, like ships are safest in the harbour, but that's not what they're designed to do. There's loads of useful analogies, but the idea is that we can do more over time and work towards those things that we should be able to get those tasks and that end goals of your program if we do this within a nice and logical, progressive way.
That makes sense.
And something that David Butler said in that video as well is that, you know, have you heard of morphine and all these really powerful painkillers?
Yeah.
You know, they stimulate this system that we're trying to tap into, and it, you know, don't be macho man. If you want, if taking some painkillers, over the counter painkillers, helps calm your system down so that you can engage with this walking and cycling, then that's definitely another option that we've got to help calm the system down. Okay, ice and heat can do a similar thing. And if I was to put an image on what this looks like, we're trying to stimulate this drug cabinet to be flushing these danger messages that are coming from your knee.
Okay, yeah, that makes sense.
Really what David was talking about in that video, because if I was to ask you, have you ever stubbed your toe?
Of course.
Did it hurt?
Every time.
For how long did it last? A week, a month?
Minutes.
A couple of minutes. You know what happened? I've just stubbed my toe. It makes sense. People are watching. Don't make a fuss. I can stimulate the internal drug cabinet and it flushes down and have pain that goes on longer than necessary. Okay. The really challenging thing with people like yourself with your knee pain is you didn't have a time when this came on. It would have made more sense if you would have just had an acute traumatic injury of when this started, and it was a tissue-based explanation where we could just let it settle down over time. Yeah. And that's why it's worthwhile us talking about these mechanisms, because these are different to tissue-based mechanisms, and that's what we're trying to do is people who have had pain like yourself for a period of time are less effective at having this drug cabinet kicking in.
Okay, yeah.
Or the metaphor that we use, it's a dry brain. And that's really important, because when we have a go at doing some of these exercises, Daniel, it could hurt. And if it hasn't been explained that this could be because the internal drug cabinet, as opposed to your knee being fragile,
mm-hmm.
It's going to be really frustrating, because you know, I've worked with people where they would see the exercise and rehab as a failure because it made them worse, and it wasn't explained that it was our nervous system that was changing, that was protecting us.
Are they sort of using the boom and bust kind of style program, and they probably just done too much too soon, sort of thing?
Yeah, and exactly, everyone's individual, and some people are more fearful, some people are more boom and bust, and that's going to be different for each person. But that's going to be one of the goals of applying this education, or this you know, talking about these concepts, because these should impact now how you're going to be going and doing walking and cycling and the exercise that we're doing in clinic together.
Okay, yeah.
Because we want to be turning your dry brain into a wet brain, and we can be using all of these things to be able to try and give us the best chance of experiencing that.
Okay, that sounds good. Yeah, it's all about managing expectations and the brain as well.
Well, that's a great, really interesting point, because we haven't talked about expectation, but this have you heard of placebo, Daniel?
Yeah.
What's placebo?
So sort of a result of something that may or may not have happened.
So in 2 words, to shorten what you just said there, it's positive expectation.
Mm-hmm.
And the opposite of positive expectation is
Negative.
And that's got another word that we use called nocebo. And the mechanism of that, because you'll be able, if you go on Google, or if you watch there's some amazing documentaries, I can send you one actually, of the power of placebo. It's incredible. It's real, it's tangible, and it is this mechanism.
Okay.
Is that when we have a positive expectation of something, we are tangibly stimulating this neurophysiology that impacts the same mechanism as the runner's high, what we, in science, we call it descending inhibition.
Okay.
Some people ask me some interesting questions around I had a bloke that I worked with once who said, do I need to believe in this process? In fact, you might have seen the case study at the start that we went through. And it was my job to say, no, I'm not going to stand here and say, let's all just force a smile and be positive. That's not real. But the basis of curses are that I'm going to prime you for 7 years of bad luck, and guess what you're going to look for after I leave you and curse you?
Not the bad luck. Or positive stuff.
Exactly. So curses don't work when you blind people to it. So if people don't know about that they're cursed, bad things don't happen to them. And the best chance of us trying to stimulate this drug cabinet in the brain will be engagement and positive expectation and immersion in the process.
Yeah. So yeah, makes sense. Sort of like positive reinforcement moving forward as well.
Yeah, and that's really where one of the biggest goals of the rehab programs that we're going to be doing is trying to give you a good experience with movement.
Yeah. Okay. You know, sort of most of the expectations I've got of movement associated with pain. Therefore, you know, it's quite a negative.
And just on that, Daniel, one of the really important things that I will be wanting to support you with is that it's not possible that everybody gets pain-free.
Okay.
So if we can not make your pain worse, but we can get you back hiking, get you back on the bike, and we can get you so that you're able to control the intensity of your training and your lifestyle, you know, but your pain doesn't get worse. That's where we're seeing function and pain being dissociated in terms of you know, that's where we're understanding the pain neurophysiology and we're able to self-manage.
Sort of understanding my own limits and that sort of thing as well.
Really good stuff. So do you have any questions, Daniel, based on what we've gone through there?
You know, you mentioned changing my brain from a dry brain to a wet brain. How long is this individual per person, or how long do you expect this to take?
Now, if I'm going to give you a really honest answer on the literature, it would say that stimulating this system, we can see clearly that people who have had persistent pain are less effective at producing this internal system. As it stands, we can't definitively say that we can turn it from a dry brain to a wet brain.
Okay.
But what we can say is that we can put a comprehensive program together. And when I say a dry brain to a wet brain, what we're actually talking about is the stimulation of these things like endorphins and reward systems. But what we can do is learn from that and put a program together that gives you the best chance of integrating and tapping into those systems. And that's going to be understanding, it's going to be physical activity, it's going to be doing things that you enjoy, and all of these things that we're going to be step by step getting you towards doing.
And they're going to be, of course, like trial and error. So some things might be good, some things might be.
And we won't know that until
we do it.
It's so important that we talked about today the fact that, you know, we might poke it a little bit, and at some point you might come in a little bit sore, and you may be cursing me that day, but we can hopefully have a chat then and look at how this is our nervous system, and when we can get through that and realize that your body's still resilient, robust after that, it will be really reinforcing for this idea that the nervous system does turn up and turn down, and we can be focused on function in terms of our body.
Yeah, and I think it's important for me to remember as well is that even when increasing my exercise, it's important to remember that, you know, because I haven't done it for a while, then pain might be there just as a sort of like a protective mechanism, but only temporarily.
Yeah, and that's where you being in control and knowing that you can dial it up and dial it down. My end goal as a clinician is to get you so that you don't need me or you don't need anybody else, because that makes sense.
Myself.
That makes sense. But of course, if something new came up and you were concerned, then you come in and ask and get some professional help.
Of course, yeah.
The last thing I want, and the big part of this program, is that you're gonna be still unsure around what pain is, but more importantly, what pain isn't, so that you're still healthcare professional shopping for someone who's going to try and find the cause of the knee pain in your knee, because you'd have probably found that by now if that was the case.
Yeah. there's there's people who have you mentioned the prescription style sort of program, so they give you sort of do this for 3 sets twice a day, and I find that quite repetitive and quite boring, to be honest.
Yeah, I mean, when it comes to performance, when you're getting back into maybe higher levels of sport, that level of prescription and variable manipulation becomes important. When we're to that point, and it doesn't seem to be that important for pain.
Yeah, it's just important to get started again.
Top man. I mean, that was a great conversation. I feel like that was that actually your knee, Daniel?
Yeah, I've had 2 surgeries on my right knee, so
that felt like a real conversation. That's exactly how I would go about now, being able to know where you're at, and then we're going to start with an amount of cycling. You've jotted down some things. I want to get them back to me. They're important, so we can touch, nudge, and tease it towards those things. And we are now on and trying to find a way of using exercise to be able to help change one essential process. That's really what, in terms of your pain booklet here, is acting on changes that happen centrally to be able to work with that with exercise and adapting the exercise to the person, which is why I know a lot of people are frustrated, but I'm not giving you just do McGill stuff. It doesn't work that way, guys.
It's all individual.
McGill's exercises helps you then take those to adapt them to a person if you feel that they could be helpful. That was really, really good stuff, Daniel. Thanks for jumping on there. And I hope that maybe that was helpful for you even. I don't know. But
yeah, no, it's sort of the similar follow myself anyway. Like I recently got back on my bike. I'm slowly increasing my mileage just week by week. So it's based off a real life experience. Yeah.
Perfect. And I hope that was helpful for everybody else in the group, and to see, because you've got access to these cards, and check out the paper, which is Rice et al. 2019. It's Hypoalgesia in people who have pain and people who don't have pain. There's loads of exercise protocols in there to give you ideas to adapt to a person. But hopefully you saw there that a big part of this is the communication. And I feel like I'd be pretty comfortable to start and get going with you now, Daniel, based on that.
So yeah, one of your patients, I'd feel quite informed and safe, and I would know that moving forward that to expect some ups and downs, but it's not all going to be positive and it's not all going to be negative. So yeah,
Top man, and it's the hour absolutely flies, guys. So I hope that was helpful for you.